Afternoon and welcome. This is Matthew Holt. I am the founder of THCB and the guy who tries to keep people under control in the THCB gang. It is February the 25th, 2021, episode 44 of THCB gang. And excited to have a great lineup today, including a special guest. So we're going to go in a second. Let me just tell you who's coming on. I have my regulars, both I call them the old men futurists, Ian Morrison and Jeff Goldsmith are on today. I only say that because they're futurists who are older than me and they stuck as being futurists, whereas I didn't last very long. Keeping up our non-white crime zone end is Rosemarie Day. We were short of women this week. I think they all had better stuff to do than hang out with us. From Day Health Strategies, regular, my former colleague at Afternoon Jail, Neptune, is now these days running Suntra Modern Recovery, substance use sort of company. And our guest today, and we'll dig into a bit of this, is Bill Taranto. Bill is the head of the Merck's Venture Capital Fund, the Global Health, the GHIF, Global Health Innovation Fund at Merck, which has done a lot recently and is very interesting. So we're going to have everyone come up on the screen. Looking forward to the conversation today. And as usual, I'm just going to start by going round and asking people what they've seen in the last week or two that spurred their interest. So we'll start with you, Rosemarie.
All right, hot seat. There's a lot of things. I think we're gonna have everyone. If you got me off, am I on mute? No. Okay, good.
Okay, go.
Good. So I am seeing, for example, in my state, in Massachusetts, this appetite now to criticize how the vaccine rollout has gone. And I think that most of us as experts know that it is pretty difficult to execute extremely well on all dimensions. And that whenever you do prioritize, that means you're leaving some folks out. And so that's going to be criticized as well. And what bothers me about this is that I think governors had to step up. Governors and local leaders and business leaders had to step up and into the breach from the horror show of what happened or didn't happen last year in Donald Trump's world. And so it just bothers me now that, so we're living with the ripple effect of those poor decisions. And the fact that, we only have 4% of the world's population, but we've had 20% of the COVID deaths. I mean, that's just so awful. And I think people now are going to be looking for somewhere to blame, but I just don't understand why it's not right back at Donald Trump, and that we give the governors and others breathing room to keep on keeping on because it's been absolutely exhausting this past year.
You might find some blame for Governor Cuomo in New York as well. But anyway, Jeff.
Well, I have a much narrower focus. I'm getting my second shot tomorrow morning at 7:30. And I'm just like wondering how long it's going to be before my wife gets her first. I mean, I understand what Rosemarie just said. It's very frustrating to think that we might have 7 or 8 months more of societal paralysis because we didn't plan to do this effectively. And not a big fan of the Trump regime. But I kind of wonder, we're the third largest country in the world. We have this incredibly decentralized system of government where responsibility for important things like public health are diffused among thousands of agencies. It's a miracle that we've gotten as far as we have, given that disability. And I think it really is a disability. What I'm sort of hoping is that, there'll be a sense in the people that matter in Congress and in this administration that we can't continue to have this disjointed an approach to societal threats that pose multi-trillion-dollar risks for our economy. This has been a far more damaging episode than any, just in lost lives alone, let alone lost wealth, than any of the wars that we've fought. And we just got our butts kicked. And it's continuing every day. So I'm kind of, I get that there's, a hunger to blame someone for this, but what was it, Walt Kelly and Pogo, we've met the enemy and he's us.
Absolutely. JL, I won't call you the enemy, but what have you been noticing the last week?
Sure. So since we're talking about coronavirus vaccines, I'm a physician. I'm not affiliated with any large organization, and I should be in, phase one of the people who are vaccinated. But I can tell you that here in New York State, I have been desperately seeking a place to get vaccinated, and I haven't been able to make an appointment. Part of it is I live in Manhattan, so there is some availability of the vaccine for people in Queens and Brooklyn. So going back to what Rosemarie was saying in terms of how things are being prioritized. But, there's still a big challenge even for people who are supposed to be vaccinated. And this is a sort of a semi-concern for me because my kids are going back to school on Friday. So they're restarting in-person instruction in the middle schools. And although I was infected in March and I hope I have some kind of immunity, I would love to have my kids going back to school with a vaccine, at least one shot in my arm. So I'm hoping that we can continue to scale our ability to vaccinate folks. And I think last time we talked, Matthew, or last time we were on, there were 1.3 million jabs happening per day, to borrow a British term. And I think that number of jabs is up to 2.5 or almost 3 million now. So I think we've increased our injection capacity, but we are still lagging very badly here.
Bill, what have you seen in the last week or so that is paying your fancy? It doesn't have to be about vaccines, by the way, although it seems to be top of mind for everyone.
No, but I'm going to follow the theme a little bit, but tie it back into a little bit what I do. With the J&J vaccine coming out, gives one hope that it might get out to the primary care level and the local pharmacy level. But what it really made me start to think about is it, even relates to things like digital health. What I do is the pandemic in and of itself, and even the vaccine distribution is shown a pretty critical problem in healthcare, where we have tremendous gaps, care gaps that have been created by the pandemic, where we don't have access to care. We're seeing tremendous interoperability problems. We're seeing tremendous issues within the supply chain. We're seeing slow adoption of just certain technologies that could probably help the situation. And one might say that perhaps this presents an interesting opportunity. But it really, I think, opened my eyes quite a bit to just, the exposure to the healthcare system of all the problems we have. And I think it was even touched upon by both Jeff and Jean-Luc that the system in and of itself isn't working at all. And, I try to think of solutions, but it's not that easy. But I just think it surprised me, really how much it exposed our system into all the problems we have. And then, of course, I try to think of digital health and where it might have an impact. But again, it's not easy because trying to align all the players in the market is almost impossible from an incentive perspective. Regulatory and compliance issues still exist with trying to get these tools and solutions out to the market. It's not easy, is what I would say, but it just surprised, really got my attention that just this real exposure to our health system.
Ian, what do you notice the last week or two?
Well, the metaphor actually is the Scottish caddies at St Andrews, right? If you leave a putt woefully short, they call it a Bon Jovi, halfway there. So I just was listening to the President Biden just before we came on, and he was having a celebratory jab, to use Jean-Luc's term, which is the 50 millionth vaccine and arm they just did today. So we're halfway there to his target in 37 days. And I think we should celebrate that. I think that's pretty amazing. I was listening to Slavitt and Walter in the Bubble yesterday in their podcast, and I was very encouraged. I'm getting my second shot Saturday morning. My wife's getting it tomorrow. So I'm actually encouraged. I do share many of the points of view everyone's laid out about it. It really displayed the dysfunction in our system. And I think, Matthew, I've been involved with Martin Luther King Hospital in LA, which was the absolute epicenter back during the holidays. And I'm happy to report that even though at that time we were 120% COVID, with 200 inpatients in a 130 bed hospital, that's dropped dramatically in the last 3 or 4 weeks. So we're now only 38% COVID, still amongst the highest in South Central or Southern California, even though I'm in Northern California. So I'm actually encouraged, and I think the precipitous drop in cases, not yet in deaths, has got to be, I think, testimony to some of the leadership from the White House, quite frankly, to Rosemarie's point. The fact that the guy says wear a mask all the time has made a difference. So I think leadership matters, and I think we're turning the corner. But, we have a system that is, dysfunctional in many ways, and this really showed, all the weaknesses and all the injustices of a system that is not well organized.
Well, I'm gonna give you my take on the week, which is a couple of things. One is been in the news. One is One Medical was given some grief for apparently letting people jump the queue, and I know you remember that, John JL. So I don't know whether you managed to do that. And funnily enough, I was actually trying to defend them because there was obviously some fog of war chaos going on early on in terms of people getting in there, but there weren't that many vaccines anyway at a One Medical. My personal GP happens to be the medical director of One Medical, and he said he couldn't, and I was complaining online that if there was so much favoritism, why didn't he reach out to me and get me on the list? But he said he couldn't even get his wife to get one. And there are some issues, actually, by the way, with, as JL pointed out, the families of frontline physicians not getting jabs. It's not clear that people who get the people who have get vaccinated can't also spread it. We just don't know that yet. And I have an employee whose husband's a full-time resident at New York Hospital, and he's exposed to COVID all the time, and she's pretty concerned about that. And given Chester works for me, I'm concerned too. The other thing I want this week, which there's a bit of fuss on Twitter about, and maybe there'd be more fuss, and I think he's in the hearing today, is Vivek Murthy, who's going to be the Surgeon General, or is the nominee for the Surgeon General, and is going to have a big role in COVID response. Was Dan Diamond wrote a piece in the Washington Post about his declarations of what he's been doing, and the last year he's been putting a lot of money in the bank from people like Carnival Cruise Lines and Netflix and Airbnb. And I was just wondering, how much we've got inured through the Trump administration with the fish rotting at the head with Trump and all the Secret Service people staying in his hotels, and Ivanka and Jared spending all their with all that massive income. And we've kind of got lost to the fact that there used to be a lot of scandal, right, around people who made money in the private sector went back into the public sector who may have influence over those regulations. Not 10 years ago, Tom Daschle couldn't basically explain what he did for the $2 million a year or whatever he was getting from the private equity fund, and lost the job of HHS secretary, which probably set health reform back, the ACA back 6 months or so back in the day. So I'm wondering whether we'll hear more about that, because why would Carnival Cruise Line be paying Murthy $400,000 for his advice when if the advice is
because I'll tell you why. Because their business was having a near-death event. Why would any of us want to go on a cruise anymore? I would want some advice about how to save my business from the public perception that it was fundamentally unsafe to be on a cruise ship.
Yeah.
So what really bothered me, Matthew, sorry to cut you off there, is that he charged even more for his speeches than Ian does.
Well, what got me is he got paid for virtual speeches. I'm sure Ian and you.
I get paid $7,000.
I worked with Colin Powell one time, and he described speaking fees as white collar crime. But well, no, I was just going to jump in. Yeah, I was just going to jump in at Jeff's thing, because I'm an advisor at Levitt Partners, and Governor Levitt and his team were I have no idea about what their billing was, but that was their big project the last year, was for Carnival Cruise. So I completely agree with Jeff. Matthew, wait a minute. But let me just reflect back. I think I go back to your old mentor, Alan Enthoven, right? I remember Alan telling the story during the Clinton administration when he flew across the country and they wouldn't let him in the goddamn meeting because he was a consultant to Kaiser. I think that's ludicrous. The only people, if you're not getting paid by somebody, you don't know what you're talking about. So I think, this sort of false kind of, oh my God, they got money for somebody. I forget about it. I mean,
isn't
compared to the Trump administration?
That's my point is, go on, Rosemarie.
Right. Shouldn't the point be that he can't be taking those gigs when he's actually in his government role.
And to be fair to Murphy, right, and there's been a lot of defense from him from the Anish Chopras and the Sachin Jains and great people in the world, is that, you know, he's steeped in public health. He was clearly a good guy. Yes, this was a big payday for him. The question I have is that, you know, have we moved the Overton window because of what the hell happened in the Trump administration? And I would go back to Tom, you know, for the Tom Daschle thing, which, like I said, probably cost the country a lot in the end, because simply he couldn't explain how he made all that money and he didn't pay tax on the driver or whatever that it was. And he couldn't take the job. And then we ended up with Borkus and God knows what else meandering through the ACA.
Matthew, I mean, what Daschle's problem, and I was watching this like a hawk, Daschle had tremendous rivalry with some key Democratic senators who really wanted to put their names on this bill that was clearly going to happen. So the argument that this was a conflict of interest story, I don't think gets anywhere close to the actual politics of what happened to Tom. Tom was thrown under the bus, you know, and I agree. He would have been tremendously helpful. They were going to get a bill done during the spring of 2009, and they had to wait a whole year and ended up with this, whatever you want to call it.
It's called Obamacare, just in case.
An owl pellet.
Somebody else. All right.
An owl pellet, a 16-pound owl pellet.
Right. It's a 16-pound. All right. Well, let's turn to our guest. So, Bill, you've been running the Merck Fund for more than a decade now, right? So, and you've seen the and the world that certainly I live in and JL lives in, and something I know Jeff was writing about way back when, and Ian and Rosemarie have been looking at of you know, this emergence of digital health. So real briefly, the thing that has always been fascinating is that when you're running a corporate venture fund that isn't just a financial fund like a Sequoia or a Kaiser or an A16Z or one of those, it's always been a bit unclear as to what the role of the fund is. Are you there to help the main big corporate figure out, you know, new innovations you're doing, or are you there to make money? And until relatively recently, certainly in health technology, digital health, there hasn't been a lot of signs of big corporate funds making, you know, really big amounts of money, the kind of stuff that the Sequoias and the Reasons do. And then a couple of years back, you invested in a small company called Livongo, and you may now fall into that camp. So can you give us a little flavor of what the job of your fund is within the wider world of Merck? And then give us a sense, and then we will pepper you with, you know, demands for money or requests about how do you manage when you actually hit a real winner like a Livongo. So give us those two flavors, perhaps.
Sure. So we take a little different approach. I mean, Merck's viewpoint of the fund is a couple different facets. You know, first and foremost, we're here to build good healthcare companies, and Merck understands that. And that's why we invest the money. Because without building a good healthcare company, Merck gets no value either being a client, or if in the future it's something they want to acquire, it provides no strategic value. So we take the approach that we're trying to build a good healthcare company. So you might call us financial first and strategic second. Our role is to help Merck find assets that they can work with and better their business. But it's more important for us to make sure these things exist in the world. And Merck understands that. So we have a slightly different remit than I would say most corporate venture firms. In the fact that the way we're structured, we're very independent. We operate as an independent LLC, and we make all the strategy and investment thesis is done by our team. We don't take that kind of direct, Merck doesn't direct us where we invest or how we invest, but we obviously look to help better Merck. But like I said, we take a much different approach. And again, our approach is more strategy driven. We're trying to make markets and change the way healthcare is practiced. And then the byproduct is Merck gets the advantage of that by working with these companies. And of course, we give them optionality. So in the future, if they want to acquire anything, you know, they have the opportunity to do that like anybody else. But we built the fund today. If people don't know about the fund, we're as you said, we're the corporate venture arm of Merck. Merck has another fund that does traditional life science investing, but we're a $500 million evergreen fund that focuses solely on digital health. We're a growth investor. So we're mostly Series C or later. We don't do any startup or seed cap, and we might do an A and B round occasionally. I would say we're the largest, if not the largest, digital health investor. We deploy over 100 million a year. And as you said, we're quite successful. Not just Livongo, we just actually had our second unicorn exit about 3 weeks ago. we just exited a company called Preventive Solutions, which is a sister company to basically Livongo in the cardiac space for $1.2 billion to Boston Scientific. And we were actually the majority owner of that particular company. And then actually last week, we just exited Decipher Biosciences to Veracyte for $600 million. We've actually exited in the last 18 months, probably close to $5 billion worth of assets in the market. So I think we're bringing pretty good value. And in fact, we took a look back to see all our exits that we've had since the start of the fund, which is somewhere around 25 or 30 exits. And the value is probably around 7 or 8 billion at the time of exit. And then we tried to figure out today what a lot of those companies are worth, and they're worth well over 20 billion today. So we're doing the right thing that we've been asked to do, is bring value to the market, try to make markets, bring good healthcare companies. And the good news is Merck's actually working with just the majority of our portfolio companies in one fashion or another. And so they're getting value. And that's what we're trying to do. But I would say, we've been very fortunate. We're quite successful. Probably the most successful corporate fund, at least as it relates to digital health, than anybody else. I haven't seen anybody have the kind of exits we're having, but we're also bringing strategic value that Merck's asked for.
Yeah, I think you could argue way back when Qualcomm was doing a lot of stuff, but they kind of fell off that place, and you guys have been there ever since. And you've also done a fair amount of sort of rearranging companies, and putting people together, putting different companies together, and then taking back and doing stuff with them. I know some in the past you've done that with, and you've got a wide variety. Let me just ask you, the one thing I never quite understand when you're running a fund, like, so you get something like Livongo, which goes public. You guys had 7% or something at the IPO, so like a pretty big chunk. I mean, you weren't quite General Catalyst, but you had real money in there and real money coming out. And then they go crazy, right? The stock goes down a bit, but then within a year, it's 10 times what it was. Now you're back in the roaring kitty business of trying to figure out, when you get out, when you get in, when you get out. How does that decision get made? Does that get made by the same investment team that puts the money in? How much influence at some point does the corporate treasurer say, okay, you've got this multi-million, billion-dollar package sort of sitting out there, I want something back? How does that happen?
Yeah, so what typically happens on an IPO, sort of on a private sale, you just get what you get, right? But on the IPO market, it works a little different. So the way like a Merck works, like much other Fortune 500 companies or any public companies, we don't typically own public stock. However, we're under the same rules as everybody else, where you typically have a lockout period. And then what Merck will do, depending on the amount we own, we own 78% of Livongo, so it was a little different situation where it won't affect the company if we then begin to sell after the 6-month period. That's typically what we do, but we watch the company. If obviously the stock's going down, we may not sell immediately. We may to see if it comes back up, but that's actually run through our treasury department on recommendations by our team as to when we actually think it's the right time to sell the stock. But Merck's not going to hold it long term, because that's not what Merck does. And then the whole idea is, all the money that we gain, it just evergreens the fund, but we don't really keep that money. Merck uses that money and employs it elsewhere, but we work off of basically a credit and debit balance with Merck. Right. So, the fund is extremely flush today. We've probably got, 5, 6, 7, $800 million to spend right now, because we've just had so many exits, and we've evergreened the fund close to, 3.5 times since we started in 2010. Which is, I think, pretty darn good for a corporate fund anyway.
That sounds great. The 5 of us are about to start up, so we can, we'll go to Series B pretty much immediately. All right. That's interesting. I've always been figuring out how do you sell and how do you buy. And I remember back in the height of the .com boom, Jim Clark, who'd done Healthy on WebMD. Then I think, JL, you and I were at that same conference back in March 2000, where he announced he was buying back in. And I think Janus Fund and a bunch of others bought into WebMD at like $78 a share, and it went to $3 a share. Or I remember that the Venrock folks, Brian Roberts, they bought some of Cast, which they taken Castlight public, and they bought some of that on the public market at $8 or $10 a share, and it went down to $1 or whatever. So, being a stock picker is a different business than being a venture capitalist, I think. Some people get a bit lost in that. Just on the range of the stuff you have, Bill, I mean, there's a bunch of stuff that, is in the clinical trial world. You've got TriNetX and, some stuff that looks like it's around very complex things like, GNS healthcare, I know you're in, which is sort of analytics. And then you've got, folks like a Yoga who are like behavior change stuff. And then, as well as Livongo and, WellDoc and that one. How do you think about what investment thesis is? Because you've done a lot of different stuff. I mean, how much of this has to go back to that a Merck or another pharma company could use this, and how much is just we're out here acting like what's the best way we can push the health tech section forward?
Well, I think part of it is one of the reasons we do that strategy-driven approach is trying to understand, what is the problem we're trying to solve in healthcare. That's kind of where we start. That's where the investment thesis comes from. Whether it's a problem Merck's trying to solve, which means that every other pharma is trying to solve, or just any other problem in healthcare that we're trying to solve. Obviously, you look at Livongo, what they were trying to do around diabetes. And that's really what starts the premise. But the way we focus our investment, we do sort of have areas of themes, I guess, if to answer your question more specifically. We look at the front end of care. So we're very interested in the whole idea of patient identification and patient stratification, which could include things like diagnostics, monitoring. It's really that sort of idea of right patient, right place, right time. The biggest part of our portfolio is what I'd call HIT infrastructure. So it's companies that do data security, privacy, and storage, data aggregation, integration, and harmonization, and data analytics and informatics. So one of our big themes right now is because Merck's an oncology company, we're looking at a lot of AI and analytics companies in, say, pathology, because we believe pathology is the future of oncology, but we're trying to look at the analytics informatics component of that. And then we look at the back end of care, which is care patient management, and how you give the patient a better journey and what kind of tools are used for that. And that, again, could be something like a Preventus or a Livongo. We do dabble in the eClinical space as well. That's new to Merck, the eClinical trial space. And we're also focused heavily on the supply chain. We recently invested in a drone company that can transport cold storage vaccines. And in fact, our company is actually working closely with Pfizer to ship their vaccines, via drone out to rural areas. We look at cold storage, we look at fraud, all sorts of areas where digital could help the supply chain. But it's all based on what problem we're trying to solve. And ultimately, as the future goes on, if there's a new problem we're trying to solve in an area that we've never invested in, we'll try to do that. But that's basically how it works. It's all strategy driven first around a problem we're trying to solve.
All right, the last question before we get us back into the general conversation, I want to get us back there, is that for years, and Ian, you and I and Jeff and everyone has thought about this, there's been this issue of, does the drug company stay over there and make drugs and let the rest of the healthcare system kind of get on with it? Or does the drug company figure out those two things collide? And obviously, the more you get towards personalized medicine, some of the stuff we talk about, even the stuff with the vaccines, which look like they're going to be more and more personalized, potentially, or what Moderna's doing. What's your theory about how big Merck, big pharma, is going to play? And I go back to Ian, when I first started working with you, right? Merck was buying PBMs and SmithKline with Mako and stuff. And there was all area they getting into the insurance game, and now we're seeing the insurers get into the provider game, and it's all getting a bit messy. So where do you think? I mean, taking off your VC hat and putting on your Merck hat for a second, where do you think the I know you have a new CEO coming up, so I'm going to change it. But where do you think the philosophy of big pharma is in terms of getting involved in care? And obviously you've got this sort of notion of digital therapeutics and stuff that's happening as well.
Well, we have to be very careful. We're under certain strict guidelines. We can't be in the corporate practice of medicine, but where we do see digital health tools, it is colliding, because the whole idea where a pharma is trying to move to is an integrated solution. So can we provide the actual therapy with some type of care management tool or something else that goes with it? And so you can imagine looking at the whole continuum. Can you provide the diagnostic up front, then the therapy, and then post-therapy, some kind of care management tool after that? And so you're starting to see, collide. I think one of the bigger issues we face as pharma are the anti-kickback, Sunshine Act laws, all the different things that we're exposed to, that we need regulatory changes in order to open this Pandora's box up a little more, because companies that like McKesson, who are not a pharmaceutical company, can actually do all those things. So one of the things that we're looking to do is push that envelope. And I think that's where you'll see pharma, because it is colliding. We need to, that whole theory, I think it used to be called beyond the pill. That's actually what's happening, but at a much slower pace, because it's not as easy to put the pill or the vaccine with some type of digital tool. And then digital therapeutics are we've seen some interesting ones. I'm not totally 100% sold on that market yet. I don't know enough. Haven't seen enough success about it, but I think you'll see big pharma, as best they can under the regulatory requirements that we're under, try to play in that game of combining digital tools with our therapeutic.
So Ian, I want to drag you in on this, because you've been looking at this for a hell of a long time. This sort of integration of the pharma guys, and just for full disclosure, Ian and I used to wander around New Jersey and God knows Kalamazoo and God knows where else. Back in the 90s, talking to these folks about the evolution of the healthcare system and what they could do, and we did a lot of projects for that way back when. What's your view of how that's changed since the 90s, Ian?
Yeah, I mean, it's really, you're bringing back a lot of memories now of discussions we had when I was at the Institute with you, Matthew, in the early 90s. I'm thinking about BMS was, ruminating about buying healthcare delivery stuff, and
Oh, right.
Jerry Carabellis, was it, who ran Smith Kline at the time, was talking about getting, deep with PBMs. It seems to me, and I've forgotten all this stuff. It seems to me that the sticking point is drugs are a 30% margin business. Healthcare delivery is a 3% margin business. So it seems to me that once you cross over that Rubicon into the delivery side, you're just diluting all the financial firepower that you've built up. And I think that was part of the shock and awe, that when it got filtered up to senior management and the board level, it sounded all plausible till you realize that running healthcare delivery was actually hard work. I'm not saying that making drugs isn't hard work, but it's incredibly profitable if you do it right. So I think
can I just comment on that? Because I think you made a really valuable point. So every farmer will tell you that, look, from a profit pool perspective, there is nothing more profitable than a therapeutic. And so there's no other business we should be in other than the therapeutic. What I think they're looking at is ways to, it's not to supplement revenue and EPS, it's to add value to the therapeutic, because I think your point is right. Nothing is going to place the profit pool that's associated with the therapeutic. It's just trying to think of how you can better deliver the therapeutic with alternate sources of tools that make the patient's journey a little better. But I can tell you now, I mean, why would a Merck, Merck will not be leaving what they do best. They're a science company that makes ethical pharmaceuticals, and they will continue to do that.
Right. But I mean, just on your point, Bill, and then maybe Jeff should jump in on this because he's thought a lot about this stuff too. But it seems to me that just to build on what you just said, that the whole focus on precision medicine and the wraparounds that are required to truly deliver precision medicine at scale does speak to this question of what can you do in parallel or in concert to deliver higher value. And I think that's a logical sort of strategic linkage to the core mission of Big Pharma.
Yeah.
And go ahead, Jeff.
I mean, if I were in your colleague's business, I would be tremendously worried about that, the vulnerability, the political vulnerability of that 30%, and how you actually demonstrate value. And the idea that I remember one of Doug Long's presentations, the IMS guy, about how, what is it, a third of scripts are never filled. And the scripts that are taken are not taken properly and therefore don't have the therapeutic effect that was intended and tested for. So there's a tremendous number of points of slippage between the discovery and the social impact that dramatically reduce the payoff from all that stuff. And I'm gonna mute my phone. Sorry about that. I looked at your strategy as in part a generational strategy. You think about the average age of your founders versus the average age of the senior execs at Merck. You're building bridges to the future of our healthcare system by investing in their ideas. And it seemed to me that the political vulnerability and the fact that you could make much more efficient use of these incredibly valuable tools that your R&D operation produces, and the issue of whether the society is getting a return on investment for permitting you to write off all of that investment. I think those are two very compelling reasons for you to do what you're doing.
No, I think you're right. And I think, if you look at even like some of the things we're doing, like I said, if you look at that whole front end of care, one of the things that is important to is that patient identification and patient stratification that gets the right patient on the right medicine instead of, and it's certainly like Keytruda is almost in a sense it is personalized because you have to express for PD-1. Not every patient can get Keytruda, but the reality is we're trying to get, to your point, get those tools out there that makes them as close as you can to precision medicine, via other tools, and try to deliver the value you're talking about. It's not easy, but that's at least our theory and how we can build good companies, but yet Merck gets an advantage of working with them.
Yeah.
And I think a very important point that Bill alluded to before, or called out explicitly, is just the regulatory framework and how that impacts innovation in this space, right? Bill referred to just two things, corporate practice of medicine, anti-kickback. But if you think about all the different things that you have to think about, especially when you're a startup, 50 state licensure. I mean, I think we forget how tight a straitjacket exists in this innovation space. And if you're Merck, you're a very profitable corporation. You probably have very talented attorneys who can help you explore this. But if you're a startup, it's amazing how much energy as a startup you have to expend learning about these regulations and then trying to build your business around those regulations. And I think, I'm always careful in terms of the term deregulation, because I think all too often deregulation means loosening the rules on the people who have power so that they can have more power. But I think that in healthcare, we need to have some kind of harmonization of the regulations and a realization that healthcare has changed, right? So for instance, I was talking about this on LinkedIn the other day. I live in New York. I live on the western edge of New York City. New Jersey is literally like 800 yards away. And I have to have a separate license to practice in New Jersey. And people in New Jersey are very similar to the people in New York. Medicine is the same in both states, but I have to have two separate licenses. If I want to practice in the bordering states to New York, I need 6 separate licenses. And that is really a very inefficient process. And, for anybody who's been practicing in the telemedicine space and really pushing the barriers there, you're really running into those issues. So I think one of the big things that the Biden administration has to do is look at the regulation on a federal level, but maybe down to the state level, and ask ourselves, how do we create, some bright space or some safe harbors? How do we create some regulations that make it clear that these are what the rules are, this is what's allowed, clarify the regulation, and then simplify a lot of this stuff to make it easier for us to practice medicine in a more modern way? Because I think that the regulatory infrastructure exists for a healthcare system that is 50 years ago,
Rosemarie.
So I'm sitting on the front lines of home health care because I have my virtual background up, but I am actually at mother's home meeting with we have 24/7 care for her. My father just passed away. We had 24/7 care for him. And I'm meeting all the home health workers and I'm seeing where all the gaps happen. And I think about this thing we call the last mile as we're trying to deliver COVID. And I'm thinking about what you're saying, Bill. And trying to reconcile. So I don't know if this is gonna be a question. I'm throwing this out here because I am literally living this. Like I go into these sessions and we have this highfalutin conversation and we talk about profit. And then I'm in this reality, this personal reality of wishing I could pay the home healthcare workers more, where the profit misalignment just seems so profound when I needed these workers to be top notch to save my parents' life. And it wasn't even so much about the drug. In fact, it was the last mile. Like, did the person give them the drug at the time they're supposed to? And that was the gap. I mean, the drugs have been invented. They're wonderful to help with Parkinson's, et cetera. But this piece is like the weak link, and it's not the caregiver's fault. It's something societal that we haven't valued the right things. And so I want to throw that in there. I don't have an easy solution, but I'm living this and trying to figure it out. And I wonder if there's any way to recalibrate here.
Yeah, let me add up sort of, I come back to you, Bill, because not to blame you for this, but there's been please historically, there's been a separation. We don't have Mike McGee on this week, who harps on this a lot as a medical historian, but there's been a separation forever between, the ethical pharmaceutical, as Ian said, it comes in a different group of R&D, it's a different type of companies building it, and the delivery of the drug as part of healthcare delivery, right? And then the rest of healthcare delivery kind of gets on with it, and it has massive gaps, as you mentioned. And I think I'm concerned when I hear about digital therapeutics that there are a bunch of people who are trying to figure out new ways of using digital technology to do healthcare delivery, but want to price it like a drug because they can see that, look at those 30% margins, can we get it prescribed and priced like a drug? Whereas philosophically, and I think you're heading this direction, Bill, it would be great to see, can we integrate all this stuff together? Because there are times when the drug really matters, and there are times when the delivery of the drug matters, and times when other stuff can replace the drug or replace the surgery, or what's the best thing we can do? And there are a bunch of players, and I don't think you have one in your portfolio, but I'm thinking about the Grand Rounds and the Accolades and the Second MDs and these types of folks, Bill, who are trying to figure out, can we reduce the reliance of the healthcare system on, the old big iron, surgery, drugs, hospitals, and get more care done better in the community by rehab therapists or physical therapy or whatever it happens to be, and can we save money doing that? There's a lot of people working on that, and it seems to me that in any event, we're going to have more complex drugs. You mentioned Keytruda as being, the Merck's, I don't know how much of Merck's revenue is, but it's a big chunk, right? It's half or something of Merck's revenue in that oncology space. You're going to have these complex different drugs, and we're Americans, we're not going to do the British NHS style. If you can't have this drug, if you can't afford, if we can't afford it. But we do have to think about, how can we integrate this, in a better way, so you don't have the sort of massive disconnect. So I don't know if you think about that as well as part of your mandate when you're talking about moving out beyond the pill, but it seems to me that's something that there is a role there for everyone to play, including the corporate venture funds.
Well, I think so. And I think if I understood Rosemarie's question, I mean, we're still not addressing, you said it's great we can create an ethical pharmaceutical, but what we're not addressing are the care gaps that exist and access, right? And so I think, first and foremost, some of the things that we should be doing is trying to help, whether it's the system or the community, to get better access to whatever they need. It doesn't necessarily have to be the therapeutic, but just get access to care. And then technology can help in some ways. In some ways it doesn't. I mean, sometimes it's regulatory issues that prevent. Social determinants of health is a big issue that we're trying to look at. Most recently is, what can we do there? So I don't have the perfect answer either. But I think there's a lot of pieces of the healthcare system we're not addressing that I think are bigger than, I think pharma companies are always going to come up with their ethical pharmaceutical drugs. I think we're going to see technology, as you said, Matt, continue to increase digital health communities, but it's not addressing some of the fundamental problems we have about just getting basic care.
And then to go to Jeff's point about the political viability, and to continue to make the case for some of the freedoms that you have, I think there's that commensurate responsibility to help us with these really tough conundrums that aren't the moneymakers, but are absolutely essential to all of us.
I mean, it's worth diving into that, because the political point that drugs are expensive, and particularly old drugs have been marked up. I mean, insulin and the EpiPen and the classics of the cases we've heard about. There's obviously political stuff around this, but again, going back to what we were doing, 30 years ago, maybe more, Ian, there was that conversation as well about how much the drugs cost in the 90s. Now we're going to have regulation over it, and nothing much happened. And I don't know if anybody philosophically thinks that we're going to have. I mean, there's been a lot of discussion about transparency. The Trump administration talked about doing something about drug pricing, but never did. I mean, does anybody feel that that's going to change significantly?
Well, I mean, there is the undeniable pressure that one of the fastest rising components of total healthcare costs are especially pharmaceuticals. I mean, that is a reality that anyone has to deal with. But I think, given where we've gone, experienced through the pandemic, and Jeff and I have been working on a piece that about health systems, but that the reputation of health systems has been advanced through the pandemic, but it's also true of pharma. Confidence in pharma is up over the last year as a result of, what was heroic contributions in terms of the vaccine development. So, as a public policy target, I think it's down relatively, but it is objectively true that is the principle. I mean, you get a group of employers. I mean, I've facilitated the PBGH board retreat a dozen times in the last 20 years. The thing that gets the employers riled up more than anything is specialty pharma prices. I mean, it's the number one irritant for them. So I don't think that's going away as a pressure. And I don't do as much stuff with life sciences as I used to, but I mean, I'm tired of beating up on value-based pricing and voluntary ICER-like value-based approaches, because it just doesn't seem to get anywhere. I mean, I think there is an opportunity for the industry to get together and say we should have science-based pricing. You know, not the NHS deciding by Congress, but I just don't see any appetite for it right now.
Yeah, I mean, you know, I think a part of the problem, I mean, it's only 10% of health spending. So,
Right.
I mean, you know, hospitals are 30, you know, so it from a standpoint of, you know, is it a fiscal burden? No. But, you know, when you say to yourself, well, okay, we spend all this money on pharmaceutical R&D. What was the last disease we cured? Well, okay, Hep C. Go back another 10 or 20 years and answer the question, what was the last disease before hepatitis C that we actually cured? That we actually had something that could eliminate the disease in 95% or better of the cases of the people we had it. So, you know, the pharmaceutical industry has this funny habit of, you know, finding a drug that works for a particular solution, and then 10 new drugs that do the very same thing seem to pile on behind them. And we don't get another Hep C story. So I think there's a lot of frustration in the general public about, you know, we're paying astronomical amounts of money for these drugs. They're very effective in certain specific targeted cases, but is our disease burden going down? Well, no, it isn't. It's going up. And life expectancy in the country is declining. So, you know, you get to the social determinants thing that Bill mentioned a minute ago. I mean, we will have had 5 years worth of declining life expectancy in the United States with a superb pharmaceutical sector. So there's a sort of a disjunction between the direction the country's headed and the direction this very successful, very disciplined industry is headed.
But I would add that, you know, as Ian pointed, the last year, right, you've seen the potential. I mean, on the vaccine side, right, clearly Moderna and you know, obviously Merck's big in vaccines, but somehow got left. I'm not blaming you, but somehow got left out of the recent one. I think I heard somewhere that Merck's actually producing some vaccines for some of the other companies, for J&J and some of the others. But you know, there's the possible part of the reason why I think as a rich country like the US can continue to invest. You know, as you mentioned, it's only 10%. We can afford it. You know, there's a lot of pressures on finances, but we're not going to not do science, and we're not going to not do R&D in pharma. You can see there is the potential for doing more things like Hep C, where you actually had a cure. You know, you actually cure a disease. You can say the same thing was true way back when about, you know, stomach ulcers and God knows what else. And there's a lot in cancer. You know, something that Merck is doing. You can say. It's not exactly a cure. You're doing a lot better. I know there's a lot more problems in cancer, of course, and oncology, but a lot of areas where things are no longer a death sentence that used to be a death sentence. So I get that, and that is part of Americans that being taught me about Americans going to the frontier and wanting to get the next greatest thing. That to me is always going to happen. My sort of overarching question is, I don't think that in the current environment, as Ian said, we're really going to go after drug pricing. There were some murmurs about it. I think there are some excesses, like, you know, the EpiPen going up by a factor of whatever it was, and the cost of insulin that really should be dealt with, and probably have some regulation. But I think the most interesting thing, and kind of where Bill's been going and putting his investments, is can you take what's understood in the pharma business? Can you add money? Can you add smart, as you mentioned, Jeff, smarter, younger people, right, who are building data products and building, you know, behavioral change products? Can you build something where that integrates? And where, you know, maybe we get the 30% margin fraction down a bit and the 3% go up a bit, like you're starting to see, at least in some of the stock prices of some of those companies that are now got out and IPO'd and SPAC'd. Can you see a way where we can actually, you know, develop a science-based, and in a wider sense, a science-based approach to doing more care and more cures? And I would then say start chipping away at that 30%, 35% that goes to hospitals and physician care, that a lot of it is semi-futile perhaps. So I don't know, that's my big picture.
Was that a question?
That was my sort of random statement.
What the hell was that?
That was my random statement about how we should change healthcare. You've got a very
smart guy here. I mean, we ought to give him a chance to answer something, right?
So, well, okay, the question for you, Bill, is is it logical to think that what you're doing, building the kind of tools and infrastructure that you're building with your, the venture fund and all the work that's been done there, is going to change the way healthcare is delivered enough that it might change both
better.
the current system and pharma? Jeff was not approving of my moderation there.
That's a much better question.
Yeah. No, I look, everything helps, right? But I think, as I said at the beginning, what was weighing on me is some of the other fundamental problems that we sort of got to think about fixing that helps in those tools and solutions work. We still have a lack of interoperability. A few years ago, my wife had a little bout with breast cancer, and I'm walking around with all the files.
Right.
Absolutely ridiculous in this day and age. And even what I do for a living, and I couldn't believe what I had to do, walking around with discs and scans, and it's just the most ridiculous thing you have in the world. And there's a misalignment. Obviously, part of the problem we have is systems compete, right? Whether you're Mayo, you're competing against Cleveland, who's competing against partners. They don't want to lose patients either, right? And so there's not necessarily a sense for them to align from an interoperability perspective with each other. That's an issue. We mentioned the care gaps. There's still not. I still think there's a slow adoption across the board for all sorts of digital tools. And I think Jean-Luc mentioned before, we have a lot of regulatory issues. This is the most complicated industry to be in. It's the most complicated industry to even invest in or build a company in, just because of all the regulatory and compliance issues that you face in building a company. And it's just roadblocks after roadblocks. And we need ways to think about opening up the system. I think getting better alignment and better incentive alignment, again, with the stakeholders. Again, I don't have a perfect answer for this, but there's other problems that are affecting really what happens that are bigger than necessarily the things that I'm investing in.
Jeff, to explain, or to at least try to jump in on the gap between increasing performance in the pharmaceutical space, or great performance in the pharmaceutical space, and 5 years of declining life expectancy. Remember, a lot of that's my neck of the woods, right? Is addiction, right? And people dying deaths of hope, of a lack of hope and despair. And, there are great medications to help treat addiction, right? Buprenorphine has dramatically changed how we treat people. The problem that we have is that we have a healthcare system that is failing. It's like a market failure. There are people who need these medications, who want these medications, and from a system perspective, we are failing in our ability to deliver those medications. Right. So, I think that those are solvable problems. Like, for instance, finding the next buprenorphine is probably hard to do, but figuring out how to get buprenorphine to people who happen to be in a rural place where they don't have great internet access, that is a much more solvable problem on a short timeline.
Well, but in the absence of trust, wasn't one of the big problems you had to go through this absurd training process in order to be able to prescribe it, and you had to have face-to-face contact with people in order to prescribe it.
Sure.
The telemedicine thing, we have to be licensed in the state that you're delivering the services in. All of that is driven by mistrust and fed by people trying to protect their franchises. The roadblocks that you talked about, why do we have an interoperability problem? Well, Bill put his finger on it, is that people want to protect their franchises and use our political system to do it. We have a really we have an astonishing capacity to help people in this care system that is just, it's muscle bound and paralyzed by all of these political factors.
I jump in and say that the vaccine thing is, the science behind the vaccines, to get that out in less than a year is amazing. And then rolling it out and doing scheduling and figuring out, it's an exact demonstration of what we just talked about, right?
Yeah.
So quickly,
I think I said this on the gang back in the day. It was vaccine chaos at warp speed. But just one final point on the pharma stuff, and an example of a disconnect is the 2% of California prisoners with HIV that actually got Hep C drugs. And I was trying to persuade one of the drug companies to do what I called all-you-can-eat pricing, is basically go to them and say, look, just give us a site license, because we're not going to get any more money. We're not buying any more at this price. Give us a site license and we'll pay you 50% more than you're getting right now, and give us as much product, because the cost at the margin per pill, if it is a pill, is close to zero. And I don't think we've ever explored alternative ways of doing deals with big pharma like that, and I wish we did. But anyway, that's a whole other day.
Well, that's another day, but that's something we do. We've done that in outside of the US, right, with AIDS drugs and elsewhere.
Right.
All right, we're close to the end, so I think we're gonna have a bit of fun now. Bill told us that he's got to spend $600 million this year, soon, whatever. We've all been looking at the healthcare system for a while. There are obviously sort of tech-enabled services that can do stuff. So if you have Bill's job, let's assume we all have Bill's job for the next 30, 40 seconds each. Where are you going to spend the money? So why don't I start with you, JL? And you can say, obviously, on Suntra Modern Recovery, but you may not need all the 500 million.
Sure. Well, we're probably going to raise some money in the next year, so you could spend with us. But more broadly and more seriously, I mean, addiction is the big killer out there, right? And, for so many, if you were to look at the decline in life expectancy, a huge part of that is driven by addiction. And the truth is, you have 20 million or more people in the country who suffer from some kind of drug or alcohol problem. The vast majority of them are not being treated or getting any kind of specialty treatment. So I'm very bullish on the recovery space, very bullish on figuring out how to use everything from AI technologies to human beings to figure out how to deliver recovery services more effectively. So please spend in the addiction space.
All right, Jeff.
I'm just at awe of this track record. I mean, I've been investing in digital health for 16 years and I'm still in the red. So far be it from me to advise a man that's actually done what he's done.
Okay, so
I'm serious.
No call from that. Rosemarie, where do you want to spend some money?
I want him to donate some money, but aside from that, in terms of
there's another part of Merck that does that. This is the investment part we're talking about.
I get it. Okay, I just had to throw it in there. I think I'm focused on the access piece, and to tie that into digital health / telemedicine, I look at rural and vulnerable populations, tying in the social determinants kinds of issues and finding ways to improve access, and technology is a piece of it, but the human factor and bringing that together, investing there, we've still got a ways to go.
Ian, where do you think we need more venture money?
Well, Bill, I think you and I should go. I've got pretty good relationships with Kaiser. I think we should go to Kaiser and I suggest that we float a SPAC with their 1.687 million Medicare Advantage members who, if you could get the same amount as Clover Health, would be 114 billion market cap. And I'll just take 10%. I'll be happy with the 10%.
As would I.
All right. Well, I have a slightly more serious one. So I think that the where we're heading, and I think, Bill, you've got some investment in this area, and obviously there's a lot of others heading. There's a kind of weird mix, right, between you're seeing the folks like Signify Health or the people who invested in Papa, who are like trying to get to that home care, sort of closing the last mile with Rosemarie's. And I think the automation of that part, which includes a lot of things that are near and dear to Merck's heart, like making sure the right drugs get to the right people and actually get taken, but also dealing with there's a lot of room for AI plus robotics plus sort of front doors, but also the human service side to manage that for all the people who don't, who aren't going to be the Silicon Valley techie types who just do it themselves, but need help and need to support the nursing staff and the homemates and the rest of that. I think that's going to be, to me, the area that what COVID has shown is that we do a lousy job in that gap area, and there's got to be a massive opportunity. And a lot of the people who already invested in, I'm thinking about the Yogos and some of the Wongos and the Patient Stations, some of those folks have got some part of that. But to me, there's a very big play. And I think that given what we've seen with how nursing homes were managed through the pandemic, but also, also how home care has been treated and, how hospital care has been under stress, we're going to really think about changing that. And I think that is, to me, where the big potential opportunity, and I don't know if that's one company or one area, but that's an area which I think, is something where a significant amount of venture capital, has gone and will continue to go. And by the way, although you've got a lot of money, I just read that Oak raised $1.4 billion for their new fund just last week. fully, they just raised 800 million about a year ago. So there's going to be a lot more of this money piling in. Even if the stock market did semi-collapse today, I think it's still going to be a big play. So now we've told you what you should do. What are you actually going to do?
Well, we still believe, we've always used this sort of phrase that data is the currency. We're going to use to transact in the future healthcare market, and we still think that's I think the interesting piece is AI and how does that then really make that data something more valuable, and whether it's treating patients, reducing costs. So I think AI tools are sort of the next big thing. When I look back 10 years ago, monitoring was in its infancy, and today you can monitor anything, and it's very ubiquitous. And I think AI is in that place right now where that's sort of where we're going in the future. But we still focus on the data component of. If you look at all our companies, they're all data companies in the end, and that's still our primary focus of trying to deliver better care and more value to the system. That's still where we're focused. But all the areas are great. I think all the areas you mentioned are places that need help from a capital perspective. And the good news is, as you said, there's a lot of money. I don't know if it's good or bad. There's a lot of money flowing into digital health and healthcare. Whether it's all being deployed in the right places, is a whole nother matter. But the good news is there's a lot of capital coming into this space.
And just to build on that, finally, going back to the point about profitability, the only thing more profitable than drugs is software. So it's
Yep, I agree.
Matthew, you're muted.
Can't hear a word.
Holt.
There you
Okay.
I
can't hear you.
I've successfully unmuted myself.
Yeah,
Now I'm
there you
attempting to show
All right.
people the. I'm trying to get the thank you screen out here. There we go. Finally made it work. I was going to say that Venture Valkyrie, Lisa Sinan, had a piece this morning saying that she's seeing lots and lots of startups come to her with the word data in the title of their pitch, but haven't remembered to connect the data to the next part where we actually do some good with the data. That's really what we're talking about. All right, well, that's the wrap on today's THCB Gang. Very interesting conversation. It was episode 44. I want to thank my regulars, Ian Morrison from Menlo Park, Jeff Goldsmith from Virginia, Rosemarie Day from the Walls of Boston, and John Neptune from New York City. And I want to thank our guest, Bill Durando from Global Innovation Fund. Great having you on here, Bill. So hopefully you can come back at some point and tell us a bit more about how well you're doing and how you're going to spend all that money the next time.
I will. Thank you so much for having me.
Useful, although you'll probably forget it.
Thank you.
All right, thank you. And THCB Gang will be back same time next week, 1 p.m. Pacific, 4 p.m. Eastern. Thanks for watching.
Right. Thank you.